So I'm going to talk about the 6 steps approach for the performance of the ultrasound exam as part of basic training and also in the outreach setting. So at the end of the lecture, you'll be able to explain how to assess fetal lie, placenta localization, and amniotic fluid volume, and also just a question now about what are the movement of the transducer to arrive to these key anatomic features of the basic obstetric ultrasound. And we will discuss those during the presentation. You know, obstetrical ultrasound is different from other ultrasound exams in the sense that it is actually difficult to perform. It's difficult to perform because an obstetrical ultrasound, well, ultrasound per se is operator dependent. Unlike CT and MRI, where the patient lays on the bed and the images come out automatically in a predetermined orientation, in ultrasound, the images are acquired by the sonographer and sonologist, and thus there is technical aspects involved on the operator perspective, and that makes it actually somewhat difficult. In obstetrics, we're looking at fetal anatomy, so this is dependent on looking we need to have great knowledge of fetal anatomy to be able to do an ultrasound exam, and the fetus is usually moving in the uterus, so we are dependent on the position of the baby in the uterus, and some of these planes that we need to look at are obscured or obstructed by shadowing either from fetal bone or from the position of the baby. And certainly maternal body habitus can limit the ultrasound, especially women with large BMI. The ultrasound may be more technically difficult. So the more we simplify the ultrasound or standardize it, the better we are able to really obtain images that are displayed in the same format all the time, thus allowing us to complete the examination. So simplification enhances training, minimizes the ultrasound steps that needs to be obtained, introduces consistency in how images are acquired, allows for efficient examination, shortens the learning curve for trainees, and provides path to automation in the future. We have devised several years back. The reason that the idea came about actually from the outreach setting as we were doing these ultrasound examinations at several places around the world. We wanted to make the ultrasound quite simple. And we figured, how could we make the ultrasound simple and devise some steps that allowing us to train better and at the same time to be able to have the trainees learn the ultrasound much faster in a shorter amount of time. So we determined, based also on the ISWA guidelines, that there are 6 important parts of the basic obstetric ultrasound examination. First is determination of the fetal presentation and lie, right? This becomes really important for women in labor, for the healthcare team to know about the presentation of the fetus. Second is determining cardiac activity, making sure that the fetus is alive. 3, identifying the number of fetuses. One of the main advantages of ultrasound is in the diagnosis of twins. As you know, before ultrasound was used quite prevalently, twins were actually missed in a substantial amount of time. So the ability to diagnose twins can really help in the management of the pregnant patient. Determining the location and position of the placenta, really critical for women, especially to rule out placenta previa, and now placenta accreta with the number of cesarean sections. Estimating amniotic fluid can have important relevance to the pregnancy per se, and doing some basic biometric measurements, which allows us to date the pregnancy accurately and also allows us to estimate fetal weight. So we feel that these are very important aspects of the basic obstetric ultrasound exam that have significant impact on management of pregnant women and directing high-risk women to deliver at a birthing center or at a hospital where services are available in case complications happen. This is the ISWAG Education Committee recommendations for basic training. And again, a lot of the components here are the same components from the basic 6 steps involved in performing the ultrasound. So what we did, we've devised these 6 steps and tested them in the outreach setting on 2 or 3 years and found to be actually quite effective in allowing the trainees to learn these steps very easily and also in obtaining information that are quite relevant to that pregnancy. So the first step is determining the fetal presentation and lie. Here you place the transducer, as you see in the image, transversely. I don't know if I can get a, can you see? Yeah, transversely on the abdomen. And here's a clip that shows you that from the transverse position, you just angle towards the pelvis of the mother, right? And the transducer has to be placed in the correct orientation, as has been discussed in prior presentations. So when you do this step, you will have really 3 options on your ultrasound screen. You will have either you see a head, like here, and then that's a cephalic presentation. Remember, you have to angle towards the pelvis to make sure that you've seen the posterior part of the uterus. If you see either feet or femurs or a breech part, that's a breech presentation. The presence of a head or a butt in the lower segment implies that the baby is in a longitudinal lie. Okay? It could be oblique, but at least from a labor perspective, you can safely say that the patient could labor if there's a cephalic presentation, because that implies a longitudinal lie, meaning that the fetal lie is parallel to the maternal spine. If you don't see neither a head or a breech part, this is most likely a transverse lie. And then you have to do more work on your ultrasound to determine the position of the fetus. So this is really helpful in determining whether the fetus is coming head first, or breech, or transverse in orientation. The second step is determining cardiac activity. Here you place the transducer transversely in the same fashion that you did for the presentation, and you slide up first towards the umbilicus in this fashion right here. As you slide up, in more than 90% of the time, you will see the heart along your path and you will see cardiac activity. Because whether the fetus is cephalic or breech, the heart is going to be in this segment right here where you are sliding your probe. If you don't see cardiac activity or you don't see the heart, then you can slide to one side or the other, as you see here. So you come up here, if you don't see anything, then you slide your transducer transversely towards one side and transversely towards the other side to complete the from 90% to 100% detection of cardiac activity. So that's the second step. The third step is determining the number of fetuses. Here you need to make sure that there's a singleton pregnancy and not twins or more. Here you have to scan the uterus in its entirety. So what we've decided to do is sliding the probe transversely along 1, 2, 3. Now here you have to maintain the probe perpendicular to the abdomen, because sometimes you can mistakenly diagnose twins if you're imaging the same head from different orientations. And to avoid that from happening, keep your probe perpendicular to the abdomen as you do so. So you slide 1, 2, 3. What are you looking for? You're looking for another fetal head. That's the easiest to see on ultrasound than trying to figure out if you're seeing 2 chests or 2 or 4 femurs and so forth. And then the next part of step 3 is going transversely on the uterus, as you see right here. So you put your probe longitudinally, as you see here, and then you slide towards 1 and you slide towards 2. So what we've done is we scanned the entirety of the uterus in transverse and in longitudinal fashion, looking for another fetal head. If you see another fetal head, then you have to confirm that this is twin pregnancy by connecting the head to a different chest and so forth. It becomes a little bit more advanced, but the concept is looking for the presence or absence of a fetal head. The fourth step, which is as important as all the others, making sure that the placenta is not a placenta previa or a low-lying placenta. Here you place the probe longitudinally, as you see in the image, and you slide the probe from the top towards the bottom in 3 parts of the uterus, looking for where the placenta starts and where the placenta ends. And as you do this, you will see where the placenta originates. So the trick is to really start at the fundal portion of the uterus. So you need to see the fundus as part of your scanning. Here you see that the placenta is fundal. Remember, we're in a longitudinal way, so that's a fundal placenta that extends slightly posteriorly and anteriorly, probably halfway down the uterus. Here's a totally anterior placenta. Here's the fundus sliding down. You see the placenta anteriorly. And this one, where as you slide down, you see that placenta is very close to the cervix. And if you see this, then the next step is to do a transvaginal ultrasound, looking at the placenta to make sure there is no placenta previa or low-lying placenta. Okay? So initially you do transabdominals longitudinally in 3 parts. If you suspect a low-lying placenta or a placenta previa, then it's advisable to do a transvaginal ultrasound to confirm that. So that's the 4th step. The 5th step is estimation of amniotic fluid. This is the classic amniotic fluid index approach, where you scan the uterus in 4 quadrants and you measure the pockets in the 4 quadrants and you add them. Most places nowadays just find the maximum vertical pocket, so find the pocket that had the most fluid and measure that one. That has been more indicative of, at least on the side of oligohydramnios, more specific, avoids you from doing interventions, unnecessary interventions, if you use the maximum vertical pocket versus amniotic fluid index. Keep in mind that to get to the maximum vertical pocket, you have to scan the uterus in its 4 quadrants. So you're doing the amniotic fluid index evaluation anyways. And the 6th step is doing some basic biometric measurement. This is the most difficult one because then it requires some knowledge and skills to find the head and get a biparietal diameter plane to measure the BPD and the head circumference, the abdominal circumference, and the femur length. So this is the 6th step. And importance of this, it allows you to date a pregnancy in the 1st and 2nd trimester accurately, and also to estimate fetal weight in the 3rd trimester. And we have found that that's the part that is the most difficult. And of those, the femur length is probably the most difficult to do because typically it's hard to find for the trainees initially. The head is easier to find. Most cephalic presentations, the head is actually in an axial plane. And also measuring that the femur is a little bit technically challenging. So when we did a study to evaluate whether the 6-step approach can find these 6 planes accurately and compared it to a comprehensive ultrasound exam, we found that it did very well. And we found that with some experience, you can perform those very easily and quickly after some training. So there was a mention of the ebook. This is a free online ultrasound resource. So I would recommend that you download it. The site is openultrasound.com. As you see, it's also available on the ISWAG website, so you can download it from the ISWAG website on the outreach segment. It has been translated to all these languages that you see here. Russian is done, but it needs to be uploaded to the website. And the Czech version was actually uploaded last month, was finished and uploaded last month. I would recommend that you download it freely and use it as part of your training and also disseminate it to your trainees. So the key points from the presentation is the ultrasound exam in the 2nd and 3rd trimester pregnancy should be approached systematically. You should, if you teach how to standardize the ultrasound exam and follow these 6 steps, you can actually take somebody who has never performed an ultrasound and within 1 week can get them to do that basic aspect of the ultrasound exam. We have seen it to be very powerful in the outreach setting. So fetal presentation, cardiac activity, number of fetuses, placental localization, amniotic fluid estimation, and basic biometry. And standardization enhances confidence in trainees and also standardizes the approach to training for basic training for ISWAG. Thank you for your attention.
I was wondering about the safety of ultrasound before 12 weeks, because what happens whenever you have, for example, an 11.5 week fetus, and you have to perform a first trimester ultrasound, and you have to measure, for example, ductus venosus or something like that. And does it depend on the time you spend on it, or is just unsafe to perform it before 12 weeks?
Well, concerning the safety, it said only when clinically indicated. So if you have a large nuchal translucency and you think it's clinically indicated to look at the ductus venosus, yes, indeed, you could look at it, but then, try to be efficient and do it not very long. That's what it's trying to say. Don't use it for just looking at the heartbeat or something like that, or just to look at the umbilical cord. But is there a clinical indication, and particularly even 11.5 week during a first trimester screening scan, then you can use it.
And what about three-dimensional ultrasound? Because sometimes I see places in which they use this, they put these very beautiful images of 3D ultrasound in first trimester, and I was wondering about that also. Does the thermal index also increases with 3D ultrasound?
No, it doesn't. The three-dimensional ultrasound makes a quick sweep, and then you can manipulate the sweep, but you're actually not scanning anymore. You have the volume already, so it doesn't increase the thermal or the mechanical index.
Okay, thank you.
But don't use the 3D ultrasound with color Doppler. You shouldn't do that.
Okay.
Yeah.
That would be like the worst scenario.
Yeah, that's not a good thing to do.
Thank you. I'll just put it back.
So our satellites, we welcome any questions. Please do send them, and we will address them all. Nothing, Terry? Okay, so I guess we'll go for early break now, and we will reconvene at 11 o'clock. Thank you.